Hello, good evening, everyone. I welcome everyone to the another Facebook Live session. Today, the 13th of January 2021. I wish everyone a belated Happy New Year and hopefully a very successful and prosperous one. I want to go ahead and basically wait a couple more minutes, let the audience join in. I am doing this from my public page versus my private page so that we can have a mass audience. Any questions that I can answer. Real briefly about myself, I'm a board certified plastic surgeon by ASPS. I'm also board certified in general surgery, and I've also been specialized and trained in burns. Having said this, I specialize in explant surgery, specifically explantation of breast implants. I also do remove other types of implants, such as implants from within the chin. And just recently, a few days ago, I did talk to another patient from California. She has a calf from within the lower extremity below the knee, calf inserts, which are made up of silicone and affecting the patient negatively in a very similar way that the breast implants affect the patients. And so she is very much, that patient is very much being affected negatively by the silicone implants that she has in her calf. And we've started the workup, and hopefully she will undergo the same workup like I do with most of my patients, such that we have worked out the other pertinent negatives and ruled out any potential problems that may be causing this patient signs, symptoms of silicone toxicity. Now, having said this, I want, if there is anyone who can alert the other audience members who are on my private page, just like they did last time, to message them, alert them that this is out of my public Facebook support group, so that I can have that audience join me here. Now, having said this, I want to go ahead and start off by talking about what each one of my patients, they on average have spent 6 months to a year researching what is breast implant illness. They have gone on multiple other Facebook groups and other social media outlets, and where they have done their homework, their due diligence, and where they feel comfortable in regards to moving forward and proceeding. And I always tell my patients there are 5 things that you must, at least from my eyes, be looking for and be attentive to, kind of which will enhance your experience and kind of confirm that your plastic surgeon is basically, at least from what I see, be understanding of what is breast implant illness. Now, breast implant illness is a very important and real topic. If you were to go to 100 plastic surgeons, I say to the ladies, almost all 100 of them would inevitably say that we will remove the current set of implants and essentially replace them with a newer set. And I say to everyone, if plan A fails, plan B should not be the same as plan A. And what are the 5 things that one must be looking at? The first and foremost, someone has to, before they proceed with breast implant illness and the explantation surgery, number 1, you have to accept breast implant illness exists. If you don't, then you basically don't have a belief or a thought process, and essentially just doing a surgery with an unnecessary cause. So first of all, the surgeon has to accept and very wisely and willfully, openly on social media that breast implant illness is real, for example, on their webpage, and then be supportive of the patients. So that's what I would say, number 1, would be a very logical approach for a patient to approach their plastic surgeon. And again, this is with all due respect to my professional colleagues, such that from what I see as a board certified plastic surgeon on a topic that is not well understood, not well defined. And if you were to go to 10 different plastic surgeons, you probably get 20 different answers. So the first thing is you have to accept the fact that it exists before you can offer the surgery. Number two, if the surgeon believes that BII exists, then by definition, you would not necessarily be causing harm to a patient by augmenting, because ultimately all implants hurt the patient. And we know this because the implants don't last forever. We know this by the recent FDA warning, the black label warning, where there is a very clear mention that the implants are not meant to be in the body forever, and that they have a certain life, and that they need to be replaced and monitored very carefully. And we know the many reasons why implants are bad. Amongst the many, number one, there is a history of the implants being banned in 1992 up till 2007 before they were reintroduced under experimental reasons and conditions where the studies would be done. Number two, we know the many patients who have explanted and how they have benefited, not only from removal of the implants, but more importantly, removal of the implant and the capsule. So that is the most important part of any discussion you should have with your plastic surgeon, where you're getting that confirmation, that confidence, that sixth sense, that feeling with absolute certainty that the entirety of the relief post-operatively, free of symptoms of breast implant illness, the entirety of the implant and capsule must be removed, and any inflamed tissue, such that when the surgery is done, there is no residual or remaining burden left behind, which means that 100% of the total capsulectomy is performed, preferably in the end block, as a well encapsulated format, such that there is no residual capsule. It is not right to leave 10% of the capsule behind. It is not right to cauterize or burn the remaining or residual capsule on top of the ribs. And the example that I've given in the past is like when you barbecue something, or for example burn something off a grill and you remove, there's still some residual toxicity, and that in itself might be enough to continue to harm and provide an autoimmune response by the body, so as to protect and hence the continuation of the breast implant illness symptoms. So going back to, this is essentially the gist of what is breast implant illness. Now, there are 5 criteria that I say are integral to ensuring that the explantation was done right. The first and foremost is the time. Yesterday, I did 3 explants, which is what I do normally, and I didn't finish my cases till approximately 8:30, which is almost 12 and a half hours into my surgical day. And the point here is, it takes on average 4 hours. Sometimes I've spent 6. I didn't start my 3rd case yesterday till 5:17 p.m. And the point here is that some cases take long, but on average 4 hours, 4.5 hours. There have been 16-hour days that I've spent just doing 3 explants. So time is very important. If someone does the surgery in 45 minutes to an hour and a half, I find that's virtually impossible to do. The second thing is the length of the incision. You cannot do an explantation from a 3 centimeter or 4 centimeter incision. The length of the incision essentially is what is determined by the diameter of the implant. And so if you have an implant that's, say for example 600 cc's and the incision is 4 centimeters, you cannot remove that implant, be it saline or silicone, from within that small hole. So you have to have a generous incision, an incision that is best, that's approached from the inframammary crease, that would allow for access, hide the scar, and do minimal muscle damage, and will allow for optimal exposure. And if the incision needs to be made a little bit longer, so as to allow for optimal visualization, so be it. Again, the goal is not the focusing or the fixation on the length of the scar, but the goal is to removing the entirety of the capsule plus the implant as one system. Number 3, the surgeon must return the implants. There are so many cases where I have done where, in the other surgeries that the patients have presented with, the implants were not returned, or the lot number did not match what was the card that was given to the patient, for example. And it's imperative and important for the patients to check and confirm that this is what was within them, and to see that an intact saline implant was removed and not ruptured, and that this is important, and that I make it a point that I return the implant 100% of the time to my patients so they can see what was within their body. And there's a lot of information that the patients can get first and foremost psychologically, that the implant was removed from the body in a very nice and sophisticated way, in the way that it needs to be done. Also, number 4, the pictures need to be taken not only of the implant and capsules, but very importantly, the pictures of the chest wall showing that the entirety of the implant and the capsule was removed and there is no residual capsule, and that preferably even a movie that shows that the entirety of the capsule was removed, because that's where ultimately the proof lies, that there is no residual capsule remaining behind. And I make it a point where I systematically have cultures that I take 100% of the time for aerobic, anaerobic, and fungal from within the right chest and also the left chest, and then followed by a set of pictures, and then I ultimately do my sponge count before I close. Last but not least, the 5th point that confirms or ascertains that the surgeon did is the reputation of the surgeon. Nowadays we all have a reputation, not only within the community, within the surgical community, but also now on social media, where one patient who has gone through the surgery can now tell with confidence, the 6th sense and part of the informed consent, the next patient that comes on, how and what their experience was, so that every patient kind of gets an idea as to how the surgeon is performing, and there is a quality control, a check and balance, and ultimately we can easily see, again, I myself offer what now the patients have been lately talking about, the Khan procedure. They themselves come in, and we'll talk about this very briefly. So again, these 5 points, if I may mention, which is again a way to ensure, confirm, and making sure I myself, basically the 5 criteria that ascertain that the surgery was done right. Number 1, the time should be within or approximately 4 hours. Now, this is my criteria that I've mentioned, that I say that at least authenticate in my mind and eyes. With all due respect, other surgeons may have their own, but this is certainly from my experience. And I say to everyone and all my patients and almost all my consults, and this is what I was telling my office manager as well, 20 years from now, I cannot imagine this surgery being done any differently, and that the goal of the surgery is to remove the entirety of the implant plus the capsule and any residual inflamed tissue, such that there is no burden left behind. And the way I do my surgeries, these are the 5 checks, at least, that I say that I would be looking out for if I was a patient and if I was doing my homework. Number 1, the length of time should be 4 hours approximately. Number 2, the length of the incision should be a good 8, 9, 10, 11, 12 centimeters, depending on what the size of the implant is. If an implant is 325 cc's, that length of the incision is certainly going to be a lot smaller than the 800 cc implant that I removed a few months ago. Number 3, the implants need to be returned to the patient. Absolute must. No, there should be no reason why the implants cannot be returned. No one looks at the implants under the microscope. And number 2, they're only the patient's property. They paid for it, and they should very much faithfully be returned to the patient. Number 4, a set of pictures that clearly demonstrate, not only on the table, but more importantly on the chest, that the entirety of the capsule is removed. And number 5, probably the most important one, I would say, and equally importantly, is the reputation of the surgeon on social media and in the general community, where and how the surgeon is performing, and the check and balance, not only on the other surgeons, but certainly on myself, that everything is being done right. And ultimately, what seals the deal, one lady from South Dakota came, and I will use her answer to kind of answer. When she and I talked, in 3 minutes into the conversation, she decided that she was going to come to me. And I asked her, this is too fast. You might end up changing your mind. I want to know what was going through your mind. And she was a young lady, mom of 5 kids, in her mid-30s. And she said, number 1, the fact that you have the YouTube videos and the Facebook posts, and I feel comfortable what you're doing, and you have that reputation online. The second thing she said, that the fact that you as a board certified plastic surgeon do not augment, you do not put in implants except for the one that I put in to get board certified, that in itself kind of seals the deal. And I said, you answered my question, and I feel comfortable that you feel comfortable. And I put myself in her shoes. And so that kind of confirmed in my mind that she was satisfied with her questions, and she certainly had done her homework. The other thing I want you to do is take notes, look at the videos. Some of the videos can be very graphic, but I always say it is part of informed consent to see what is going on and how the surgery is done, so you can understand the lingo, you can understand what is being done on a topic that is not well defined. The other thing I want to mention is insurance will never, and I use the word, and I want you to please quote me, insurance will never cover what would be a total capsulectomy and block, a 4-hour procedure, because their payment professional fee is essentially minimal to none, in the $700 to $1,200 range approximately. And this would absolutely not justify a surgeon's 4-hour or so commitment. Certainly an hour where the part of the capsule is left behind, and an hour, hour and a half, and that in itself nullifies the purpose and the nature of the surgery. Now I want to go ahead and talk about what the patients have been saying lately. They come in and they call and say, I want this Khan procedure. And I say, you know, it is certainly unique from what I see and hear from my patients and my colleagues, that I'm the only surgeon who has consistently done, and number one, no need for drains. So I've done, for example, of all the surgeries that I've done last year, I've only placed drains in 3 patients, where they came in essentially with what was free-floating silicone within the chest, where I made the incision, and lo and behold, the silicone was essentially, literally free-floating, and that automatically mandated placement of drains. Many patients have asked, how come you don't place drains? You're the only person, you're the only surgeon who does not consistently. And I say to each one of them, number one, I approach each and every single case as an en bloc. In my mind, I'm prepared, or a total 100% capsulectomy. And I go super slow, at the same time fast enough, where I'm dissecting very meticulously in this avascular plane. And you will see from the many videos on YouTube, and I'm going to have hopefully a whole lot more on Facebook, where the dissection is essentially in a bloodless field. The blood loss is 3 cc's, 5 cc's on each side. And the need for the drain is not there. As simple as that. If I find that there is significant inflammation or free-floating silicone, which automatically mandates a drain, I will put one in. If I think about it and I feel that the patient will benefit from a drain, I will go ahead and put one in, because I can always remove it the next couple of days once the output is less than 30 cc's. But I will tell you, in my hands, even patients who have had 800 cc implants, the one that I talked about, and she was on prednisone and she was in her mid-50s, and I still did not place a drain. And the vast majority of the cases, even with silicone that was ruptured extracapsularly but all contained, I was able to remove the entirety of the implant and the capsule as one system, and no need for the drain. And you can see from the videos, it's a very clean surgery, and the requirement of the drain is not there. Putting a drain in would be detrimental and hurt the patient. And so I've been very judicious as far as use of the drains, and I've used the drains in those cases happily and readily where it's required. If there is any spillage of silicone within the chest, automatically that mandates a drain, because you will have that residual inflammation that will induce and cause continued inflammation. So you will see in almost 99% of my patients with saline implants, and well over 97-98% of my patients with silicone implants, I have not had the need for drains. And I'm very happy to say that the surgery can absolutely very safely be done, and very correctly being done. There was an explanation by one of the other nurses who came to me who mentioned just recently, 2-3 days ago, in regards to her understanding of what is the need for drains. I agree with that. I approved of that post on my private breast implant illness support group, and and that is in a very nice way, such that the patients can understand why and how I don't use drains. And I say this to all my colleagues, my plastic surgery colleagues: absolutely, the surgery can be done. The goal is to go super slow, but in the right plane. And when I use the word slow, when you go slow rather than zipping through the surgery, there is less trauma to the neighboring muscle. You don't cut into the muscle. You don't leave any residual capsule behind. You're in that avascular plane where essentially it's a bloodless field. The patient has a better post-operative recovery. The patient has preserved anatomy, and also the patient has less pain post-operatively and less need for pain medications. There's so many patients that don't even use the Norco but for 1 or 2 days, or the tramadol. Now, some patients do for a longer time because they may have more inflammation, for example, on one side versus the other. But I'm very happy to report that very meticulous, very sophisticated, technical dissection using the Povey cautery allows for no need for drains, and it is very, very achievable. And I have a track record. One patient in pre-op mentioned to me, I'm very happy, that she was very happy with proceeding, but she requested that I'd place drains. And I said, I'm not going to place drains because you asked me, or the rest of the other 10 surgeons are placing drains. I'm going to place a drain because I feel in my mind that you need one, and it's safe to place one versus given the risk versus benefits. To have drains in the chest, number one, that's a window to the outside. Remember, the drain will allow suction through the GAP, or the bulb syringe, a negative pressure that would allow for that fluid that would accumulate within the chest to collect in this reservoir. Remember, the drains themselves may allow, potentially, if that bulb opens, fluid to track back. The drain itself sometimes may introduce or may induce some of the body to react and make some fluid. The drain is there to accumulate any unnecessary fluid, and if the surgery is done correctly and done right, and again, 99% of my saline patients, if not more, maybe 100% of my saline patients do not have drains. And like I said, last year, of the many explants that I did, I only placed drains in 3 patients, and it was on only that one side where the free-floating silicone was. Number 2, the part of the Khan procedure, 80% of my patients do not need lifts. Now, there is a whole series of reasons why one may need a lift versus not. You have the age of the patient. The day before, on Monday, I saw a patient. She had significant weight loss. She had ptotic grade 3 ptosis of the breast tissue, and she had implants. And I told her, absolutely, despite you being in your late 30s, you're absolutely going to be a candidate for a lift. You need a mastopexy, essentially rearrangement of the skin such that you would have a normal anatomic preservation given to someone who is 37. But the many ladies, as you will see, in their 30s, 40s, and even 50s, have not had the need for the drains. And this is consistent with the fact that I make a cut at the inferior aspect, at the inframammary crease. I don't touch the breast tissue or the nipple areola complex. As soon as I make the cut through the skin at the inferior crease, I identify what is the capsule and I ride the capsule. What do I do so I'm underneath the muscle in the majority of the cases, because this is where the implants are placed in well over 90%, 95% of the patients, well below the muscle, which is the standard of care. Now, only in athletes, for example, or people who work out or who choose to place the implant above because of surgeon preference, which is only a minority, the dissection essentially is otherwise below the muscle on top of the rib. What do I do to the breast tissue, which is above the muscle? Nothing. I do nothing, because then I leave that anatomy alone. I don't distort it. And when I do dissect below the muscle, my entire surgery is below the muscle, below the pectoralis muscle and above the rib. So the entire anatomy of the breast tissue is preserved. And what I do is I have the binder / the compressive bra, just like a gynecomastia patient. I've posted that patient and many other patients that I've done. That gentle compression but firm and comfortable compression allows for that tissue to recoil especially in a young lady, and allows for the tissue to be relocated in its normal anatomic position with preservation of the anatomy of the breast tissue and the chest. And again, once the surgeon is writing the capsule, that allows for nice meticulous dissection and allows for a nice aesthetic contour in a result, and hence no need for a lift in the vast majority of the patients. Nowadays, and unfortunately, if you go to 10 surgeons, almost all 10 of them will inevitably put a drain in 100% of their patients, and they would very likely push for a lift or mastopexy. Now I say and respect my colleagues unconditionally. I respect the way they're doing it, but I say to you, it can absolutely and safely be done, and my proof are the many patients who will come forth and other patients who have been part of other Facebook groups. And for example, Tracy Gary, she's like one of the main representatives here for the state of Michigan, who's been very important nationally and internationally in regards to promoting breast implant illness, especially with the FDA, and is major advocate of breast implant illness. She will now tell you that a lift is not required. And I did talk to her. There is a YouTube video that I have as to when the lift is required and why I choose not to do lifts. In the vast majority of the patients can and will do well. To do mastopexy, that's an involved surgery, especially when it's not required. And so I say, and this is part again of what I offer my patients. And I'll say, I'm a big fan of surgery when done right, but not surgery when it's not necessary. And I'm a big fan of D&T, which means do not touch. Let it be. Let the body take its natural course. And I say to every patient, in my mind or thought process, that day, my fixation is to remove the entirety of the implanted capsule, which is a 4-hour commitment. I do not want to do another 2 hours. And in order to do a true or a good mastopexy, you have that lollipop and an anchor incision. I do not want to be basically involved in doing another 2 or 3 hour operation, which is a very easy operation, but I don't want to mix the two. That will only compound the picture on a day where the fixation should and only be on removing the entirety of the capsule and letting the patient bounce back to a normal state of health. Now, absolutely, there are patients who need a mastopexy at the same time, and I can determine that easily. There are some patients, given the significant volume that is lost, a patient will certainly be a candidate for a lift. But vast majority of my patients, if I were to estimate, 80% of them do very well and very good aesthetic results post-operatively without a lift. Even the 55-year-old patients that have come post-menopausal, where the elasticity of the skin has been gone. So on an explant day, when the surgery is done, there's 3 volumes that a patient loses. The volume of the implant, obviously, number 1. Number 2, the volume of the capsule, which can be pretty extensive if this is a thick capsule. And number 3, the volume of the inflammation, the dilated veins, the lymphatics, the dermal lymphatics of the skin, the engorged dilated veins and the tissues, the interstitial fluid edema. And you will find the many patients that have come forth, and I salute and thank each one of them that have shared their story. There's a nice lady from Virginia. She lost almost 30 pounds. Another lady, she lost 20 pounds. Another lady, post-operatively, she lost 12 pounds. And this is the inflammatory fluid that they were retaining as a result of the inflammation that they had on their chest, and not only on their chest, but their joint pain, the arthritic pain. And this is the body kind of detoxifying and essentially cooling down to what would be a normal state of health. So going back to what is the Khan procedure in summary, at least so far, and I'll continue to go through. Number 1, no need for a drain, essentially 99%, 97+% of the patients. Number 2, no need for a lift in well over 80% of the patients. Number 3, I give the implants back 100% of the time to my patients. There was once a time where I did a case at a hospital, and the charge nurse was absolute, implants cannot be returned. Later that night, I called the chief pathologist at the hospital, and I said, I have to get the implants. This is my patient. My patient paid for them. And the recommendation was made that a letter be submitted to the committee. After a discussion I had with the pathologist and a release, I was able to go and get the implants and personally deliver them to the patient, because that was my bond with the patient. The implants are not processed. Remember, they were inside the patient's body. If they are in a biohazard bag and a sealed bag, and that is in another biohazard bag, that it's certainly very safe to handle, especially with gloves. Remember, if it was in a patient's body, it is certainly very safe to handle in a biohazards bag and contain it in the way that it needs to be, and it is absolutely safe to process. Unless it was placed in formaldehyde, that's a different story. Then that agent or other agents that it's placed in, that can be toxic. So that in itself is a separate story. And so the implants, number 3, need to be absolutely 100% of the time returned. There are patients that refuse, that say, we don't want the implant, we're taking a flight back. I say, no, still take the implant home, bring it back on your post-op visit, and then we will go ahead and discard it in biologic waste. But it's important for the patient to see them psychologically. It's relieving to see that the implant is out, and plus to confirm, what was put in is right. I have had patients that have had silicone implant on one side, saline on the other. I have had a patient where the lot number did not match what was the card given to the patient. I have had another patient where she had Allergan on one side, and believe it or not, the McGann on the other side, or the Mentor on the other side, a different model. And so it's important for the patients to know what was within, and that it was removed intact. The sealing bag was not ruptured, the sealing implant was not ruptured, and that they were removed in the right professional way. So going back to the 4th thing about the Khan procedure, what I do unique, different, is the twilight sedation, which is the deep sedation, comfortable sedation, safe sedation, where the patient is in a deep sleep. Some people like to use the word kind of like a comatose state, where they have no recollection, no hearing, no processing. They're literally in a deep sedation, deep sleep. And literally, what that means is breathing on their own. This is safe, it's effective, less risk for clots, less risk for aspiration, amongst the many other problems that come with potential ventilation. When a patient is ventilated on general anesthesia, the patient is essentially paralyzed. The risk for clot, the risk for the pressure ventilated, for example, barotrauma or pressure trauma from the ventilator, amongst the placement of the tube, amongst the many other reasons. Now, there are plenty of times where I've used that, for example, in patients who have heavy reflux. I don't want that acidic fluid from within the stomach to go into the lungs. That's going to be a major problem. So I selectively, along with my anesthesia team, basically, I absolutely recommend and suggest that we put the tube. Or another patient where I was operating, she had an abscess on her implant. This is how she came and presented, and in order to do my dissection around the muscle, I requested that the patient be put under general anesthesia for the patient's comfort. This was a select case, one out of maybe the 250 that I did in the last year and a half. And before I intubate, I basically would give the heparin 5000 sub-Q. All 100% of my patients have the SCD boots, or the squeezy boots on the lower leg, so as to prevent clots. This is with the twilight and also the general anesthesia. And I say to date, not a single patient has come forth who has said, I heard my surgery or I woke up during my surgery. All of them have had very good experiences intra-op and post-operatively. Each one of them has bounced back relatively very nicely, because this was very controlled and contained, safe anesthesia. So this is the 4th thing that I do consistently that's different compared to the many other surgeons. Number 1, no need for drains in vast majority of the cases. Number 2, no need for a lift in roughly 80% of my cases. Number 3, twilight sedation. Number 4, the implants are returned 100% of the time. Number 5, 100% of the time, I send the capsules off to pathology. It's important to remove the capsule and send it to the pathology department so they can look at it under the microscope and do a CD30 analysis to rule out BII, ALCL, which is the breast implant associated anaplastic large cell lymphoma, along with malignancy, breast cancer. Remember, when the pathologist looking at it under the microscope, if they see any abnormalities, for example, they're looking and they see hyphae, which is suggestive of fungal infection, that will alert the doc. Over the winter break, I got a call from the pathologist saying that he saw a lot of T lymphocytes and there was concern for lymphoma. I said, work it up, oncology department. We need to do all the battery of tests because we want to make sure that there is no lymphoma. And if you don't send it, you're not going to know. The eyes don't see what the mind doesn't know. And if you don't send it to the pathology department, and in a disease that is consuming the patient from the head to toe, from the hair follicles to the headaches to the vision, sinus problems, the teeth, the Sjogren's, the dryness, the changes in vision, headache, the neck, back, upper neck pain, the shortness of breath, anxiety, depression, all these symptoms, the tachycardia, the arrhythmias, the autoimmune issues, the rheumatological issues, the joint pain, the GI issues, the rheumatological issues, the endocrine issues, plantar fasciitis or ringing in the ears, the metallic taste, all of these symptoms, this is the inflammation. We should at least send this off to confirm. And lo and behold, as you will go and see from my Facebook Live with Dr. Mowers from 3-4 months ago, you will see that there is proof that chronic inflammation is there. There is, mentioned many times that silica is present, refractile material consistent with silica, giant cell reaction. There is foreign body reaction, and again, all pointing clearly evidence towards what is breast implant illness. And that is the proof. Ultimately, if we ever need to go back and refer to those slides, are there, that evidence is there, and that is part of the complete workup. Now remember, on a side, any patient who has lymphoma, the CD30 analysis is positive, and BII LCL, it is mandated, required. It is the standard of care to remove the entire capsule plus the implant and any inflamed tissue and any fluid, and that it is malpractice to leave any of the capsule behind. So again, it is important. If you're not going to test, you're not going to know. And the FDA very clearly acknowledges that the number of cases of BII LCL underreported because no one sends the capsules off, because no one is, number one, removing them. And if you're not going to remove them, no one's going to know how many and what cases there are, especially related to textured implants, and absolutely in non-textured implant cases, but to a much lesser extent. So going back to the Khan procedure, the drains I don't use. Number 2, the lift. Number 3, the implants are returned. Number 4, the capsules are sent to the pathology. And number 5, I always 100% of the time take cultures from the right chest and also from the left chest once the capsule has left everything, because if there is any residual bacteria, and believe it or not, there are 10 to 15% of my patients who have had Propionibacterium echinis, other bacteria such as staph that have been noted and that have been associated with implants. Sometimes they lead to the capsular contracture, and it's important to note that there is no residual infection and that there was no fungal infection. Now, it's very rare to get a fungal infection, but at least we have ruled that out on a disease where patients have spent years and years in misery and countless and tens and hundreds of thousands of dollars over the years trying to figure out what the problem is. So at least the set of cultures are important process, and I usually have both the pathology and the microbiology that's processed through the patient's own insurance for what is something that's very physiologic, that the FDA recently acknowledged as breast implant illness, and hopefully the medical community will acknowledge, the primary care doctors and all these subspecialists, that there is absolutely such a thing called breast implant illness, and it is a real entity. Hopefully it will be assigned itself another ICD-10 code as a disease, such that the patients get reimbursed very appropriately for what is a relatively expensive process to go through, given the length of the surgery and the post-operative recovery, and certainly all the pre-op workup that the ladies go through before ultimately they conclude on their own with certainty that this is the BII that is hurting them, especially in their mid-20s, 30s, 40s over the years. So now, having said this, what I want to do is, what you can do is, I want to go ahead and answer any questions anyone may have. So if you could please, you can ask questions. I want to go ahead and entertain any questions anyone may have so that I can answer them. I'm just seeing who is watching, but for me to see who is, what questions they may have, I'm trying to see what is there in the comment section. How about aesthetic flat closures? Yes. So this is a make comments full screen. So the patients that have history of breast cancer, they have the implant. They don't have any breast tissue remaining. They may have fatty tissue, which we have on the sides. And the goal there is that is usually replaced with set of implants that are large, from 550 to 750, given the fact that the patient has no breast tissue. Now, in reconstruction, like I did my first case from Panama that I did yesterday, a lady from out of the country, she had alloderm reconstruction, which is cadaveric skin. My goal is to remove the entirety of the implant plus the capsule plus the alloderm, which is the cadaveric skin used in reconstruction, especially at the major university centers, and then to remove what would be an elliptical shape such that when I do close, there is a tension-free, nice aesthetic flat closure by definition. And this is part of the reconstruction of the chest, and one needs to take into account if there's any history of radiation, especially the side that has the cancer. And I always make it a point to send that mastectomy scar, especially on the side of the cancer, to pathology to rule out any residual. So an aesthetic flat closure is absolutely relatively easy to do when a football-shaped elliptical excision of the mastectomy scar is made, such that there is a nice aesthetic contour. And I'm going to go ahead and post some more pictures. Some ladies have basically sent some pictures as well. Now I want to mention, as you will see, lately I have not had any pictures from the OR. I was basically blocked from Facebook for one whole month, and they said my pictures were too graphic. And so what I'm in the process of doing is I'm going to start posting them on YouTube with a cover, basically alerting the viewer that this is going to be graphic content, and I'm going to have a series of intraoperative pictures and videos. I find the videos are the best, where you will see with certainty the avascular plane, the dissection, and I'm actually operating. So you will see my aesthetic closures, and as I continue to dissect, how I dissect, so you will see, and hopefully we'll have that up. I have made it a point now, I'm not going to post anything from the operating room, that is patient related or surgical related, because I know the next time I get locked out of Facebook is going to be 3 months, and I don't think I'm going to be able to handle it, and I would not, meaning as far as not being able to give any feedback whatsoever. And I tried desperately, like the president, to change and to come on as another, using Shaher Khan under a different account, but they were able to pretty much pick up right away that it was me again. And I basically tried opening up another account, but the point being here, I'm going to have those pictures up hopefully within the next week, so that you can see the aesthetic flat closures and how I start off. I'm reading the questions right now. Now, I want to mention that, I respect all my plastic surgery colleagues. I have a different approach, and I would say my approach has been tested and tried and proven. I feel very comfortable, for me to come on Facebook and discuss. One of my friends is a very close friend. He said, Khan, what are you trying to do? You're taking videos and posting from the OR on a topic that is very hot, not truly accepted, negated, and considered a myth by the vast majority. And hopefully, and I said, let me go ahead and prove my point. Number one, and kind of proved it to you earlier. Number one, all what I'm doing is what I'm telling the patients I'm doing, which is part of that informed consent. And this is that the consent form, which clearly states what I'm doing. All what I'm doing is removing the implant, and I'm guaranteeing the removal of the capsule plus inflamed tissue. I'm not doing anything more or less. And this is the very much standard of care. Like I mentioned earlier, if someone has lymphoma, the capsule must be removed, and that is the standard of care. And leaving the capsule behind is malpractice, is gross negligence, and not the standard of care. And it's like leaving cancer behind. So all what I'm doing is removing the capsule and the implant as one system in a technique that I defined in the en bloc fashion, or a total capsulectomy. And there is no spillage of the silicone within the chest. I'm not putting drains in. I'm not doing lifts. I'm doing minimal surgery. And I'm having a whole series of patients that are bouncing back and happy with their post-operative outcomes, and obviously relief from the BII symptoms. So this is very much safe. This is very much, the standard of care, what I would say. And I will say 20 years from now, I cannot imagine in my mind how anyone would do it any differently, and how I say this would be what the patients have been very well saying, and coming from far away, what would be the plastic surgery procedure. How long after surgery can you resume physical exercise and swimming? So that's a good question. So swimming is a pectoralis function, and the latissimus and the upper extremity deltoid. Now, if you have the pectoralis muscle that's on the chest, it inserts onto the humerus, which is the upper arm bone. So anytime you lift something heavy, or you open a heavy door, or you lift a baby up that's 2 years old, like many of my patients, you're going to inevitably use the pec muscle. Remember, in the vast majority of the patients, the implants are below 95% or more of my patients, and in general, the implants are below the muscle, and the dissection is done on top of the rib below the muscle. So the dissection is in the proximity. You don't want to be using the muscle. You might go into a spasm. And the goal there is, from the muscle repairs that I have done, be it in the leg or in the hand or the arm, not related to BII, it takes 6 weeks approximately for the muscle to recover. And so post-operatively, day one, when someone's texting, or what the ladies talk about, the T-Rex arms, where the elbows are pretty much at their waist level and their their lower chest, they're allowing for that healing of that muscle and the chest to occur, and where the compression is there, and then the recoil of what are the chest skin supported. During those 6 weeks, enough of a recovery occurs every time someone opens, for example, a drawer, or drinks a cup of coffee, or opens the car door week 2, 3, 4. That is all recovery and healing that's occurring. Now, once the 6 to 8 week mark passes by, then I tell the patients, gently start 3 or 5 pound weights, and then work up these weights so that you're lifting up and down. And then what it does is it allows 5 to 7 minutes in the morning, 5-7 minutes in the evening, and gradually working up. So not only are you building the pec major, but the pec minor, the latissimus, and also the deltoid and the upper function of the chest, which truly could not be utilized because the implant before was sitting underneath the muscle. And so now at the 6 to 8 week mark, I tell the patients, then you can start incrementing over the next week to 2 to a state where you can start reaching for the upper shelf and start lifting heavy objects slowly as you see fit. And then at usually the 8 to 10 week mark, you can go swimming, you can go snowboarding. Like one patient came last week and she said, I want to go snowboarding. I said, absolutely, go ahead and race, start working up. 2 weeks later, you can go snowboarding because you meet criteria. And then I have the patients kind of pull up against resistance, and if they feel no pain, then I give them the green light. Now, swimming is a lot of pectoralis function, so I tell them, you have to wait the 6 to 8 weeks before you can do that. And the patients themselves will say, oh, I did, like with my basketball, I had a teenage son and I did a 3-pointer, and they will feel the spasm where they will feel the pull. And I tell them, your body is telling you, don't rush it, go slowly, incrementally, and work up to that level. So usually at the 6 to 8 week mark, and everyone being different. The 26-year-old lady is going to have a lot more beefy, strong, red, very well perfused, very good blood supply muscle, young muscle, versus the 72-year-old who has attenuated, somewhat atrophic muscle. And remember, if the implant is below the pectoralis muscle, the patient is not able to utilize the muscle. So if a lady has implants for 20 years, like the lady that I did the Facebook Live, 23 years, she truly cannot use the pec function, because every time she uses, she's going to press against the implant, against the chest. So truly that muscle gets attenuated with age, with lack of use, and sometimes even gets atrophied, and sometimes even disintegrates such that the implant starts falling out. And that's why they use the alloderm. And again, going back to the point, the reconstruction is different in the different age groups. And so some patients are able to bounce back sooner, some later. Now, there are patients who are athletes, for example, bodybuilders. They will always get their implants placed above the muscle. Now, their recovery is very different, because what happened, it's below the breast tissue and above the muscle. So the dissection is essentially very different, very quick, very enhanced recovery. And so those patients in 4 weeks will ultimately bounce back to a good muscular function. Are capsules ever in the fatty tissue by the armpit? No. So sometimes what happens is, remember, any foreign body in the patient's body will form a capsule around. So people who have pacemakers for their heart, people who have ports, chemo ports, people who have artificial knees, for example, the body in itself, even around titanium, it will form a capsule, a shell. Now, what happens is, sometimes when the surgeon has placed the implant in the chest and the patient starts flexing, what happens, the muscle sometimes presses and the implant gets displaced laterally. Usually that's the path of least resistance. Or sometimes, if placed from the axilla, the implant moves up, because that's the entirety of the capsule forms, and sometimes it can rotate. And the point here is, I've seen in patients where, because the placement was done through the axilla, the implant truly did not sit down, and when the patient started flexing and extending her arms, the implant would migrate up. So the capsule now had a path to move up and down, and every time the patient would flex, the implant would move up and out, because that's the area where on the lateral side, on the outer side, the implant, so the capsule would move to that or would extend to that. So that was an extended capsule. Another lady I did approximately before the winter holidays, she had her implant that was riding to the side and to the front every time she would move. So she had a relatively large capsule that I had to do a more extensive of a dissection. So absolutely, the entirety of the capsule needs to go. And remember, in a nutshell, I know my patient's recovery, my patient's good health, my patient's symptoms of BII are only going to be relieved once not only all the implanted capsules are removed, but also the inflammatory the inflammation, the fatty necrosis. Sometimes there might be focal inflammation that may be present, that may be hard, that must also be removed, because you don't want to leave that burden behind. One of my patients came in and said, well, your capsules are a little bit thick. And I said, well, that's part, if you feel the fat and that tissue, it is inflamed. It is much different compared to the other side where the capsules are very thin. And so it is important to take that inflammatory flow, the inflammatory tissue, because otherwise you're going to leave that inflamed tissue behind, and the patient will continue to hurt. And again, the goal is to leave everything normal behind, because that's volume to the patient's chest. Would a possible secondary plastic surgery be needed? I'm not sure. No, it's not uncommon where you do like closure, and it is not uncommon to do like a touch-up under local. If someone gets a tummy tuck, a patient has a small dog ear on the side, very normal. Someone another prominent plastic surgeon does a facelift, for example, and there is an irregularity and may need a touch-up, absolutely, that is fair game and not uncommon. And usually the surgeons are very good about waiving their fee and doing it under local, because those fixations can be done under local in a very defined and quick way, and they're only a fraction of what the initial surgery was. What is the name of my YouTube channel? Is Khan Plastic Surgery Academy. If you Google me, Shaher Khan, or type in breast implant illness Shaher Khan, you will see, hopefully I will come up. So can you do anything with cysts or lumps in the lymph nodes along the breast? So believe it or not, there are many times where I run into cystic contents of the breast, and the goal there is to remove anything and everything that is abnormal. Now, I'm very particular about making sure my patients are worked up appropriately. I make sure that they have had a mammogram. If there is any suspicious masses, I tell each one of my patients, go get your workup at a breast center. Don't come to me. I don't want any surprises on my operating room table. There are patients that have come, I've never had a mammogram, I'm 57. I say, I want you to go ahead and get cleared, because technically 1 out of 8 or 9 women are going to get breast cancer, and I don't want to on my table. If I technically operate on, let's say, 100 patients, you can only imagine how many of them, if I were not to filter them or screen them, they may have masses that may eventually be breast cancer, and I don't want that to happen. So there are patients that have had mammograms that might show something, or an ultrasound, maybe an MRI, and worked up by the breast center, and I know there are cysts, then I don't leave them. Because remember, vast majority of the patients, the implant is below the muscle. I'm in that department, in that section below the muscle. What am I doing above the muscle? Nothing. I'm not touching it. I have nothing to do. There is no business up above the muscle, because I'm only going to distort the breast tissue. And I make the cut at the inferior crease such that I'm able to access the implant and the capsule and not touch the breast tissue. Now, if I run into any lymph nodes, I absolutely take them, and I've sent them to pathology, because they're, number one, maybe inflamed just from breast implant illness, but we need to make sure there is no potential malignancy or cancer, because that is an abnormality, and we need to send it. I did a case from Massachusetts. She came in, and I was dissecting, and a large mass, believe it or not, the size of a tangerine. Now, guess what? It was a nice, kind of the size of 2 golf balls, if you will. Nice size mass. And guess what? The workup was done. She had already seen her doc. There was actually evidence of a lymph node in the axilla. And she had been worked up, and I knew that there was a mass in the axilla. I knew that on clinical exam, and I was dissecting, and I saw this mass. And I'll go ahead and post a picture so that you know what I'm talking about. And it was very dramatic. Now, I tried to dissect. I didn't know what it was. And I said, it might be a lipoma, because it had all the features of what was a fatty tumor. Now, after my dissection, and I took a sample of it, what would be an incisional biopsy, and I sent this off. And I said, I'm going to hold off. My goal of the surgery is to remove the entirety of the implanted capsule. And I took a biopsy of this mass, and now we know what we're dealing with. And I did not want to dissect that mass. Certainly I could, but that would be maybe 1, 2, 3 hour operation. And my goal of the surgery and the consent with the patient was to remove the entirety of the implant and capsule. Now, there are plenty of times, for example, if I'm doing a tummy tuck and I run into a mass, I'll take a biopsy, and obligated in taking a biopsy, because I need to know what it is. Now, if it's small enough, I will remove it in its entirety. But if it's large, I will at least biopsy it so that the patient now can get a workup. It's very similar to when I was getting trained for general surgery, and I'm a board-certified general surgeon for those who missed. I'm also a board-certified plastic surgeon by the one and only board that certifies plastic surgeons, by ASPS. We go in and try to do a gallbladder, and we see a mass of the ovary. We don't remove that mass or call the OBGYN to come in and remove. We take a picture and then send the patient over if we have to, and we can safely biopsy it so that it helps the diagnosis. and will help the OBGYN colleagues. If there is a mass of the kidney, then we know that we at least biopsy it if we can. Sometimes we don't want to touch it because it might be very vascular. But certainly in this case, I took a biopsy, and lo and behold, it came back as a lymph node, and I will tell you it was the same lymph node that extended from the axilla. Now, one thing we have to do whenever you see any lymph node of the chest, it's breast cancer, or we need to rule out breast cancer till proven otherwise, because we want to be super ultra safe. And so the point here is, now the patient was told when she heads back to Massachusetts, she needs to go to a major medical center, and she needs to go to that same surgeon, and she needs to get like a full workup MRI so that we can define this mass that connects potentially with this one, and she can ultimately get it removed so that she can get a diagnosis and hopefully confirmation that there is nothing surprising later on, because that is a mass that needs to be absolutely looked into. So this video, absolutely, I'm going to go ahead and take all my Facebook lives and I'm going to put them on YouTube. So Khan Plastic Surgery Academy is, and please, you can Google me. There's only 7 Khans in the US who are plastic surgeons, and I know each one of them very well. And so you will see, you'll see me if you Google me or YouTube, search me, and you will be able to find. Again, I want to thank, I see Debbie Ann, she's the nurse. She's the one who gave a very nice overview as to the need for drains, and I was the one who approved it, and I thank you very much for help clarifying. Sometimes, you know, my lingo, my language that I use can be very technical, and I help. I thank Debbie for helping analyze it and helping the patients understand. I thank my many other patients who basically go above and out of their means to help the other patients. You know, at the end of the day, you know, someone mentioned the Khan sisters, and I say this to everyone. Yes, we are one big happy family. We have one vested purpose to help each and every one. We have no desire to question or criticize. We are all trying to define what is breast implant illness. We're trying to help the thousands and hundreds of thousands of ladies and the millions that have implants, so that they understand what is a real problem. And like I was saying when I was interviewed by the local TV that was aired last week, you know, this is a real problem with a real solution. You know, implants are notorious for their badness. They are not worth it. They cause a whole series of problems. Number one, they're associated with lymphoma, BII-LCL. I will go ahead and summarize. They have been banned, the textured implants. They've been associated with contracture, pain. They've been associated with infection, just like any implants. They're not meant to be there forever. You can see that the implants have been banned before in 1992 for the same reason that we're reliving again all these symptoms of breast implant illness. The questionnaire that I have, if you call Jennifer, that she will send to you, where you can check off boxes, and we have ladies in their 20s, 30s, 40s, 50s, 60s checking off more than half consistent with what is breast implant illness. And I say to each and every single patient and viewer and listener, to the plastic surgeon, to the doctors, this is the one surgery where 2 things remain effect to date, and that will hold true literally forever. Number one, not a single patient of mine has ever regretted removing implants, number one. And if anything, each one of them said they would not have gotten them. And number two, they all had wished if they could, they would have removed it sooner rather than later, so that they would not have been troubled and be in misery as a result of the implants. And I say to the plastic surgeons, to the many other PCPs, the primary care doctors, and also the many rheumatologists who are screening and looking at the patients, and the psychiatrists who basically keep turfing this off to fibromyalgia. Breast implant illness is very real. It's being talked about more and more. The FDA has acknowledged this. Now the Cosmopolitan magazine, the Fortune magazine has talked about it. There are local news channels and groups. There is a documentary that was done on me where they came and basically interviewed me and basically filmed me in the OR. You know, a lot of evidence is coming forth, and especially the literally tens of thousands of ladies that have come forth on social media, YouTube, Instagram, and Facebook, and shared their journeys. And again, the more we pleasantly talk and very humbly alert the medical community that this is a real entity, Facebook Lives such as this, so that we can teach the many that have not even heard of what is breast implant illness, so that we can better the quality of lives of the many. Now, with having said that, I'm going to go ahead and conclude my session today. I wish a belated Happy New Year to each and every one of you. I wish the very best, and hopefully you do well with COVID, and that you keep the distance and keep the masks, for that has been shown convincingly to help the thousands and the millions, and hopefully very soon this will be behind us. Having said that, God bless everyone. Take care, and thank you very much.